Good morning, everybody. This is our first attempt to do a hybrid grant round. So there will be people outside in the chat. I guess some people from Mainz also have dialed in. It is a great honor and pleasure to welcome Professor Romans from Mainz to Zurich. He has a long history of dealing with a topic that he is going to present to us, fragility, fractures of the pelvis. I remember when I was a young resident and he was appointed to come to Mainz. He came from the biggest trauma center in Belgium, from Leuven, and he actually beat some of the most prestigious opponents that were in the last round with him, and he was at the time very well known for his treatment of acute high-energy pelvic fractures. I think he had published as one of the most publications and important publications within Europe, at least, and the pelvic ring was always one of his focuses. He is a very academic person. He has been the general secretary for Estes for many years, and he was able to structure many good things that affect our profession, which are still ongoing with Estes. And we also share a few things together. When I was very young and I had to pursue my academic career, he helped me in writing an assessment for me personally. And as far as the acute and current situation is concerned, we also share some memories because in 2015, I think it was, when we went to Ukraine, and the Ukrainian trauma and emergency surgery group, they wanted to join Estes, and so we went together. Back then I was Estes president and he was the general secretary. So we went over there and gave lectures in order to welcome them to Estes. And he is still in touch with people from there. Currently it's a little difficult to get a hold of them and we don't know really what's happening, but it is one of the common memories that we have. And I think the most important development that you have done, Paul, is the foundation of a new classification for pelvic fractures for fragility. I have heard some of the aspects of your talk before, and I have always been very impressed how meticulous you have been presenting and preparing the cases and how you developed this classification. And so it's my particular pleasure, I have to say, to welcome you to give the lecture on fragility, fractures of the pelvis from eminence to evidence. Paul, please.
Yes, dear Christoph, dear colleagues, ladies and gentlemen, first of all, thank you very much for your nice introductory words. It's a very honor for me to be here and to present this fragility, fracture of the pelvis knowledge we would like to share with you in the frame of the Harald Tscherne Honorary lecture today. First of all, I would like to pay tribute to this man. This is Marvin Tile, who influenced my professional career very much and who is also, I would say, the father of our biomechanical knowledge of high-energy pelvic trauma. You know, his very important publication, milestone publication of 1988, where he writes, he is the only author where he writes or answers the question, should this high-energy trauma pelvic fractures be fixed and what kind of treatment should we offer them. He is also the father of the classification of the pelvic trauma, distinguishing between open book lesions, lateral compression lesions, and vertical shear injuries. And indeed, at that time, we were confronted, as Christoph already mentioned, with many patients with high energy trauma due to traffic accidents, falls from great height, and crash traumas. So many of our polytraumatized patients at that time had a pelvic ring injury, and many patients with a pelvic ring injury were polytraumatized. And we learned to provisionally stabilize these patients when they were hemodynamically unstable with a pelvic binder, with C-clamp, or an external fixator. And if the patient survived and they became hemodynamically stable, we then offered them a definitive treatment in the sense of open reduction and internal fixation, using our different principles of stabilization. But today, we are confronted with a different patient population. If you look at this graphic, the median age of the populations in 2020 in different large countries in the world, then you see that Japan and Germany are on the top of this row. That means that 50% of their population has an age of above 45, respectively 48 years. And that means that we are confronted today with older people, also older people with pelvic trauma. This is a publication out of 2014, and the authors looked at the discharge diagnosis of all patients that were treated in the hospital in the United States between 1993 and 2010, an 18-year period. And you see there were 250 million discharges. And of them, 3.5 million had classical hip fractures. Due to osteoporosis, we know them. About 500,000 had pelvic fractures, and less than 100,000 had acetabular fractures as main diagnosis of discharge. But what you see here in the same publication is that the incidence of the classical hip fracture is declining since 1996 to 2010 with 25%. And in the same period of time, but the absolute numbers are different, you know, 3.5 million, 500,000. But the incidence of the pelvic trauma is growing in this same period of time with 25% as well. We see a similar evolution in Finland, publication of 2015, where you see the age-specific incidence of low-energy pelvic fractures for man and woman divided into age groups. And you see them, the evolution from 1970 to 2010, and then further an extrapolation to 2030. And for every age group, men and women, you see evolution towards a very, very rapid increasing incidence. A similar publication comes from the University of Düsseldorf, Joachim Windolf, we know him. And in this publication, you see this graphic, also an age-depending incidence of low-energy pelvic trauma for man and for woman. And you see above the age of 80, there is a very rapid increase of this incidence. The German Pelvic Registry has 3 different documentation periods, 91 to 93, 98 to 2002, and 2004 to 2010. And you see a clear shift in the largest group of population that has a pelvic trauma. In the first documentation period, these were young men, and in the second or third documentation period, it shifted towards older women. Already present before, but the group is just increasing rapidly. And now we are 2022, so 12 years later than there, and this has going on until today. So with this increasing incidence of fragility fractures of the pelvis, we are confronted with new questions. Are the pelvic fractures similar to those of the adult population? What are the differences and how relevant are these differences in terms of diagnosis and treatment? Do this classical classification systems of Tile, AO or Young-Burgess still fit for these older people? And do the same therapeutical principles apply? Yes or no? What are the differences between pelvic lesions in adults and in the elderly? And we see differences in the clinical picture, in the characteristics of these lesions, and sometimes we have also specific features in these old people with fragility fractures. First of all, in the clinical picture, we don't see so much hemodynamic instability. So it's very seldom in the FFP population. Nevertheless, it exists. And therefore, this group around Michael Blaut from Innsbruck recommends that you should hemodynamically monitor these patients during the first 24 hours after admission, because some of them may have an insidious bleeding that can be life-threatening at the end. This is a consecutive series of 11 patients, and they have been treated with a specific angioembolization and have been saved. So if there is a bleeding, the treatment should be an arterial embolization. For what concerns the characteristics, in the elderly population we are confronted with weak cortical and very weak cancellous bone. And here you see a publication of our group in cooperation with the ARI in Davos. Daniel Wagner looked at the 92 healthy Europeans, older people, and constructed a three-dimensional statistical modeling of the sacrum. And then he divided this into two groups. In a group of patients with a higher bone mineral density in L5 and a group of patients with a lower bone mineral density in L5. And if you see on the left side, the group with a higher density, you only discover small islands of, we call that alar voids. That is, these are islands where there is no bone mass anymore due to extreme osteoporosis. This is colored in yellow. And it is situated between the neuroforamina S1 and S2. But in the right group with the lower density, you see that these alar voids are much larger. They start in S1 and go to S3 and are situated always in the massa lateralis, the lateral mass of the sacrum, mostly bilateral. And sometimes you have a small island of this alar void. It's not an alar void, it's a corpus void then in the center of the sacrum. Here you see an 89-year-old female. This is a reconstruction of her CT scan. She has an incomplete ilium fracture and a pubic ramus fracture. But what is striking is these alar voids in the sacrum on the left and the right. You see large areas where there is no bone mass anymore due to this extreme osteoporosis. And that is the reason why we see different fracture patterns in the FFP patients than in the high energy trauma. These fractures are always situated in these areas of alar void, so in the areas of the lowest bone mineral density. And this can be unilateral, as you see on the left, through a vertical fracture to the massa lateralis, can be bilateral, and sometimes these two fractures are connected or incomplete connected with a horizontal fracture that goes from left to right. And at the end, on the right side, you have a spinopelvic dissociation, But this is a totally different clinical picture than the suicide jumpers fracture that we have in the younger population, although the fracture looks similar. Third, specific features. Indeed, we see that in the older population, the pelvic ring is collapsing between the intact ligaments. So it's the bone that breaks, not the ligaments, which is different in the younger population. There you have an explosion due to a very high energetic force. And what we also see is fracture progression in people. Mostly they are treated conservatively, so the new fractures occur during the therapy of the first fractures. Here, a patient with a specific morphology. If you look on the left side in AP view, then you see that the sacrum is tilted down. So there is an intrusion of the lumbosacral segment into the small pelvis. So the sacrum is lower than the ilium, both sides. And you see on the right side a huge pelvic instability on the pubic symphysis. This is the same patient, left and right. If you look at a CT scan, you have a bilateral, complete iliosacral dissociation. And this is something that you really very, very seldom see in high energy trauma. Mostly, this is a unilateral trauma with a iliosacral dissociation on one side. Another example is this patient with two fractures of the posterior ilium, left and right, and again an intrusion of the sacrum with the lumbar spine into the small pelvis. This is the inlet and the outlet view, and you see with these small steps that indeed the whole vertebral column with the sacrum is going down into the small pelvis. So it's a collapse of the whole pelvic ring. The other point is this progress of instability. Here you have a 57-year-old female with a very intense osteoporosis for her age. You see that on the X-ray. And she has a low energy trauma and has nearly undisplaced pubic rami fractures bilaterally. This is treated conservatively. And you see after 2 weeks, the fractures are slightly displaced. The patient still has pain, but the treatment is continuing conservative. And after 3 months, you see that there is a massive displacement of the fractures in the front bilaterally, but there is now also an insidious fracture of the right ilium beginning in the sacroiliac joint. So you should say, is this a fracture or not? We will follow that. This patient was further treated conservatively, and after 5 months, there is a complete fracture of the right ilium, and now there is a clear indication for surgery. Would say this cannot be treated conservatively anymore. Another example is an 83-year-old female. These are pictures immediately after trauma, an AP view, and then 3 different CT scans where you see slightly displaced fracture in the front and in the back. We will speak about classification later, but you can treat that conservatively, certainly. This patient comes back 3 months later and it's nearly impossible for her to walk. So immobilizing pain, and you see a clear fracture progression. If you compare that with the previous CT scan and X-ray, you see now more displacement in the front and a bilateral fracture in the back on the level of the massa lateralis, as I said before. We looked at this characteristic in 148 patients, so it's a retrospective study, and we found a fracture progression in 21 of them, so it's about 14%. In all of the categories of instability, there can be a progress of instability towards more instability. And these were 21 patients. 20 of them were treated conservatively. So it is most frequent in the conservatively treated patients. And in one patient, we had a fracture progression after a unilateral treatment, operative treatment, and he it was a man, he got a fracture on the other side as well after this operative treatment. So to summarize so far, we have specific characteristics on these fragility fractures of the pelvis. A result of low energy trauma, weak cortical and cancellous bone. The fracture patterns reflect the areas of the lowest bone density. We have specific fracture morphologies like bilateral fractures, H-type fractures of the sacrum. The ligaments are stronger and only affected in chronic cases. We have seen 2 of them already. The bone fails between these intact ligaments, so we have a collapse of the pelvic ring instead of an explosion due to high energy trauma. And in some cases, there is an increasing instability over time. For us, these were all arguments to look for a new classification system because we thought that the existing ones did not reflect the specific characteristics. So we looked back at 245 patients that came in older than 65 years old, that came in our hospital and had a CT scan and conventional X-rays as well. And we were able to develop a classification system that reflects most of these characteristics based on 2 criteria. The first criterion is the degree of instability from low to high, and the second sub-criterion is the localization of the fracture in the posterior pelvic ring, be it the ilium, the sacroiliac joint, or the sacrum itself. And we were very proud that the editor-in-chief of the GBGS American, in his letter, endorsed our classification system and says that this will benefit elderly patients. This is Mark Schwalinkowski in 2019. The classification is based on the analysis of conventional X-rays and CT, not on MRI, because we think that the bone is the problem here, not the ligaments and the soft tissue structures. Here you see 2 good quality X-rays, and you very nicely can detect the fracture progression between the left picture and the right picture. And here a CT scan, this is the second line diagnostic, indispensable we think in this case, just as in high energy trauma. And we are able certainly to analyze the posterior pelvis in detail with this CT scans. And here again, you see a fracture progression in the same patient between the left and the right picture. If we take a CT scan, we should make 3-dimensional reconstructions in the coronal, in the oblique, and in the sagittal way, so that we really can see in detail where these fractures are starting and where they are running. If you look at the axial CT on the B picture, then you see this, let's say, small fracture lines in the front, but you don't see them in the back. If you look in the coronal CT scan, then you will see that these fractures go from front to back, so they are complete fractures. And even in this picture D and E, you may see this horizontal connection between the left and the right side. So you are able, if you take some time and analyze the pictures, to really see all the details and to classify these pictures correctly. The first group in our classification system is the Ffp1 category. And these are isolated anterior pelvic ring lesions, be it unilateral or bilateral. And in the group of 245 patients, we saw this in about 18% of our cases. So isolated anterior pelvic ring without any trauma in the back. What does that mean? That does mean that 80% of this group of 245 have a posterior trauma that is detectable with conventional X-rays, especially with CT. So if you only take conventional X-rays after a patient, in a patient that is coming in your emergency department and you detect a pubic ramus fracture, you may underestimate the severity of the trauma because in 80% the patients will have a posterior lesion as well. That many times is not detectable in the conventional X-ray. We analyzed 519 patients during an 11-year period in Mainz with an FFP. And 138 of them had really an isolated anterior pelvic ring lesion. So 26% of them. And look at these characteristics that we found out and calculated in retrospectively. So you really can say these are serious adverse events for elderly persons. You see 8 days of hospital stay, 1 year mortality of nearly 17%. The reference value in our country, Rhineland-Palatinate, is between 4 and 6%. So it's tripled. And the European Quality of Life 5 dimensions has a value of 0.62, where the reference value is 0.78. So there is a diminution also in the quality of life of these patients after such a, let's say, benign fracture. And there is a reduced mobility with the Parker mobility score only having a value of 4 out of, in a scale of 0 to 9. The second group is the largest group, FFP2, and there, this is the undisplaced posterior lesion. The undisplaced posterior lesion can be isolated in the 2A without anterior lesion, can be a crush lesion like a lateral compression lesion in the younger population, or can be a complete fracture of the sacrum together with an anterior pathology. And in the group of 245, we encountered this classification in 50% of our cases. So this is the largest group with an equal distribution between FFP2B and 2C, so the crush lesion and the complete fracture. And also there we had a look at this characteristic. So again, this group of 519 patients, in this retrospective study, in 46% of the cases, an operative treatment was done. This is only FFP2, huh? An operative treatment was done in 21% or 22%. You see a median length of stay of 10 days, a 1 year mortality of 14%, not higher than in the FFP1, even a little bit lower. And a reduction of the quality of life as well with SF8 and with the Parker mobility score measured. If you now compare the group of operatively treated FFP2 patients with the conservatively treated FFP2, you see 186 against 52. Then what you see, the length of hospital stay is doubled after operative treatment, so you cannot discharge them earlier. There is an equal incidence of general in-hospital complications, so there is no influence from the type of treatment on the general in-hospital complications, but there is surgery-related complication incidence in about 1/4 of these patients. So surgery has also disadvantages. There are complications in these frail patients in 1 out of 4 patients. What was striking for us, and perhaps very nice for surgeons, the mortality of the operative group was significantly lower than the mortality of the conservative group. And we are talking here about FFP2, because this is always a point of discussion. What should we do with this large group of patients? After this retrospective study, we did a prospective study in 2019, 2020. And these were 110 patients, 59 of them had FFP2. And you see the characteristics here in this prospective documentation were the same as in the retrospective. Yeah? But the operative treatment was a little bit done more, about in 1/4 of the patients. Also there, we compared the operative group with the conservative group. And what was striking is that the patients with the operative treatment were admitted in the hospital nearly 2 weeks after the onset of complaints, where the patients that were treated conservatively were admitted immediately after their fall and the same day admitted in the hospital. That means that the patients with operative treatment, they did not know about a trauma. Most of them, you see here 42.9% could not remember any trauma. So they had pain and perhaps there was a fall, but they could not remember it. And this was treated by themselves or by a general doctor in a conservative way. And only after 2 weeks, if it does not work well, they were admitted in the hospital. And then they were treated operatively by us. The third group is the group with the displacement of a fracture on the posterior pelvis unilateral, through the ilium, through the sacroiliac joint, or to the sacrum. And this was the smallest group with 11% of the cases. In the fourth group, we take them together, these 3 and 4 categories, were bilaterally displaced fractures through the ilium, through the sacroiliac joint, or through the sacrum. And you see here this category 4B is this category with the H-type fracture. We were very surprised to see, and in our calculation, this is the classification paper, that in our observation, this was in about 14% of the whole group, the case. So this higher degree of instability was not very seldom. Together with the FFP3, this was 30% of the cases. And indeed here, the retrospective study on 519 patients, there you see 24% of them had FFP3 and 4. And in 70%, we treated them operatively. In 30%, we treated them conservatively. The median length of stay was 15 days. You remember 8 days for FFP1, 10 days for FFP2. Now we have 15 days. The mortality does not raise. It's about the same. And we see in all these patients a reduction of quality of life again, 32 against 50, and the Parker mobility score of 5 in a scale from 0 to 9. And again, when we compare the non-operative group with the operative group, then you see that the length of hospital stay is more than doubled if you operate on them, which is certainly a negative aspect for these patients because length of stay produces also in-hospital complications. Nevertheless, the incidence of general in-hospital complications was not significantly higher in the operative group, although we had in 1/4 again of our patients a surgery-related complication. You remember this was the same in the FFP2 group. And what was also very nice for us, here again, there is a statistically significant difference between the operative group and the conservative group what concerns mortality. The operative group has a lower mortality, overall mortality. And in the prospective study, we had 37 patients out of 110. We operated 90% of them, so we learned from our retrospective study and did more surgery in these unstable patient groups. And you see for the first time, we had a mortality below 10% now. You know, we always had some mortalities around 15%. In this group, below 10%. Nevertheless, the quality of life and the mobility of this patient was significantly reduced as well. And again, if we look at when were these patients admitted in the hospital, that was for the type 3, 6 days after the onset of complaints, and for the type 4, 41 days, so it's 7 or 6 weeks. That means that we think that this patient started with an FFP of a lower category of instability, and then this during the conservative treatment outside of the hospital, there was a fracture progression, and at the end they were admitted with an FFP type 4 fracture. And see again here down that 45% of them could not remember a traumatic event previous to the hospital admission. Now, what to do with these patients, how to operate them if you want to operate. And also here, we performed a retrospective study in this large group of 519. We had 140 patients that we operated on. And we divided this group into 2 subgroups, one with a percutaneous procedure, anterior and posterior, or anterior alone or posterior alone, and an O group with an open reduction and internal fixation. And you see there is no difference in the length of hospital stay. There is a difference in the length of post-operative hospital stay. That means the open group had 2 days longer hospital stay. What was significant? There was no difference in the incidence of in-hospital complications, but there was a very significant difference for what concerns the incidence of surgical complications. You see 19% in the P group, percutaneous group, 43% in the group with open reduction and internal fixation, which is highly relevant. Most of the surgical complications were implant failures. And there was a need for surgical revision in more than 1/4 of the patients with open reduction and internal fixation. So here we deal with a frail patient population, and we should be very careful with this aggressive type of surgery that we learned from the high-energy trauma, as I showed you before. So the percutaneous procedures are certainly our preference. Looking at a specific type of treatment in the anterior pelvic ring was the plate fixation for instabilities of the pubis or fractures very near to the symphysis pubis. And there Mr. Hertele looked at 48 of these patients of 140 and looked at what happens with the plate fixation. And you see there were 37 patients with a single plate on the top of the symphysis pubis, and there were 11 patients with a double plate, an additional plate anteriorly. You will see some examples later. And there was a screw loosening in 45% of the superior plate, mostly near to the symphysis pubis because the bone mineral density is very low there. It's stronger near to the acetabulum and in the ilium just above the acetabulum. And there was a revision surgery needed in 16% of these patients with single plate osteosynthesis. In the small group of double plate osteosynthesis, we did not see any loosening in the anterior plate, and we did not have any revision surgery. So if you think you need to do a plate fixation, it is advantageous to perform a second plate anteriorly in order to have enough stability. As I said, we prefer now percutaneous procedures, and there we have different alternatives for the posterior and the anterior pelvic ring. You see sacroplasty, SI screw osteosynthesis, the transiliac internal fixator, the positioning bar, and the lumbopelvic fixation. And this is the largest study of sacroplasty from a patient group from Los Angeles. 243 patients treated with sacroplasty. You see a CT scan from one of these patients. From this publication, a decrease of the level of pain from 9 to 2, no major complications, only one cement extravasation. How is that possible? Because there was no fracture of the outer cortex of the sacrum. So there was a bone bruise the indication was done on the basis of an MRI and not of CT scan, and because there was no real fracture behind and in front of the sacrum, was no extravasation. But here you see another publication of Bern, where they looked at 33 patients, and there this population is different because there is a fracture, a real fracture of the sacrum with an interruption of the cortex. And then certainly you have a cement leakage in the fracture gap in about 27% of the cases. Here you see a patient that came to us after sacroplasty. You see this is the CT scan before the treatment was done. You can see an infraction of the anterior cortex, an incomplete fracture of the sacrum on both sides, and this patient was treated by a neurosurgeon with a sacroplasty. Look at the cement. There is a leakage behind the sacrum. There is a leakage inside the sacroiliac joint. And the patient came to us because she had continuing pain. And you see here a CT scan before sacroplasty, immediately after sacroplasty, and 2 months later. And what do you see? A progress of instability. So your sacroplasty did not help, did not prevent the fracture progression. There is another fracture now in the front, and there are bilateral displaced fractures in the back now. So for us, we do not use sacroplasty in these patients with complete fractures. It's not precise enough. It does not give a high stability, and it does not prevent against fracture progression. Iliosacral screw osteosynthesis is very well known from high energy trauma. It is an accepted procedure for trauma of the sacrum, the lateral sacrum, and the iliosacral joint. Here you see a 75-year-old with a failed conservative treatment, a complete fracture of the sacrum on the left side, treated with 2 long iliosacral screws and a retrograde transpubic screw in the front. There have been positive publications for this treatment in older patients. You see here from the University of Köln, 30 patients treated with this technique, a very low incidence of complications and revisions, and a significant reduction of the pain level. Nevertheless, we know that from the work of Daniel Wagner and others that the bone mineral density in the sacrum is low. So here this patient was not treated in the front for a pelvic pubic ramus fracture. You see them bilateral, but was only treated in the back with relatively short iliosacral screws, and already after 1 week there is a loosening of these screws and there is a need for revision. And if you look at this publication from Basel, 50 patients, total revision rate 20%, classical iliosacral screw osteosynthesis, mostly due to symptomatic screw loosening, and revision in 9 of these 50 patients. So a possible solution can be that you augment your iliosacral screws with cement. This is not the same as the sacroplasty because the cement is situated in the center of the sacrum, not in the fracture gap, and is inserted through an implant. And this study from University of Regensburg together with the ARI showed that there is a significantly increased fixation strength if you augment these iliosacral screws with cement. A publication of Münster looking back at 640 iliosacral screws for high energy and low energy trauma. Of this, in 488 patients, 148 of them had an FFP. 99 of these FFP patients had a segment augmentation. And there was, calculated by the statisticians, a reduced risk for major complications in the patient with augmentation and a 25% reduced time from surgery to discharge due to a significant diminution of the level of pain. The transiliac internal fixation was conceived for high energy trauma, so an extra a posterior stabilization system outside of the sacrum, and it can be used as well as a percutaneous procedure for the FFP patients. You see are two pedicle screws that are inserted in the posterior ilium and then connected with a horizontal bar between the left and the right side. You see a 75-year-old patient very near transsacral corridor, so it's difficult to place implants there. It's a patient with a chronic case. You see already a healed ilium fracture. Now she has bilateral sacral fractures and bilateral anterior pelvic ring fractures. And in this case, we performed a transiliac internal fixator. You see very nicely the pedicle screws in the ilium, left and right, and the horizontal connection. And here, two retrograde transpubic screws and augmentation of the posterior construction with two iliosacral screws. An 81-year-old female with recurrent falls, pain since several months, FFP4B fracture. You see some pictures of the CT scan, severe displacement in the front, bilateral fractures in the back, and in the sagittal reconstruction between the S1 and S2, a horizontal fracture with displacement of the lumbosacral segment in flexion. And this is it looks a very aggressive surgery, but it is in reality not so aggressive. The whole construction in the back was done percutaneously through very small incisions. So the internal fixator, two long screws in the sacral corridor S1, and a double plate osteosynthesis here in this case because of an instability very near to the symphysis pubis. And you see this patient 1 year later, she is able to walk with a frame and she is still at home. There is only one publication that looks at this transiliac internal fixator with a group of 15 patients in Regensburg, and you see that there were complications in 16% of them, and but after 6 months, all the patients had a fracture consolidation. And the conclusion was that this is a safe procedure for this group of patients. The transsacral osteosynthesis has been described about 10 years ago by our group in Mainz. And what you do here is, if there is a good corridor in S1, you make an implantation of a bar about 6 millimeter, and then on both sides of the bar you put washers and nuts to slightly compress this left and right ilium against the sacrum and to enhance the stability in these vertical fractures of the sacrum. You see an example here, 68-year-old female, an FFP2C fracture, and this was treated with a sacral bar and an iliosacral screw in the back. And in the inlet view, you very nicely see that these washers push against the posterior ilium and give an additional stability so that the patient is able to walk immediately after the surgery. Another publication, or another example, excuse me, you see an instability in the symphysis pubis, so it's a chronic case with a lateral mass fracture on the right side. Also here, transsacral bar and double plate osteosynthesis in the front, and 3 months post-operatively patient is doing well. Daniel Wagner from my group looked back at 85 patients treated with this technique, so transsacral bar osteosynthesis, and you see we had surgical revisions in 15%, certainly not in 40%, so it's lower than in the open techniques. We had a lower mortality, below 10% again in this patient population, and for the survivors, follow-up of 3 years and more, 85% lived at home, 82% were able to walk independently with or without walking aid. In the FFP3 lesions, these are the 3A lesions, the fractures through the ilium. Then you can say, oh, here we certainly need a plate osteosynthesis because this is a large fracture. And indeed, we did this type of surgery previously. Here you see the CT scan of this patient, and here you see the kind of treatment, the first window of the ilioinguinal approach, a large fragment plate parallel to the sacroiliac joint with lag through for the iliac crest, the inlet and the outlet view. But when we remember the high level of complications in this patient's group, we tried now to do the same stabilization in a percutaneous way, and we found this publication from Japan where they describe a technique of iliac intramedullary stabilization. So they use the supraacetabular corridor from the anterior inferior iliac spine to the posterior superior iliac spine, a very long trajectory, but you can place a straight screw in that. And I show you one example where this fracture is also visible in the ilium, in the conventional X-rays and the CT scan. And here you see this so-called interdigitating stabilization, these very long screws that go through the fracture site without any reduction. So it's a percutaneous technique, and the retrograde transpubic screw. The last possible treatment is the lumbopelvic fixation. You can do that in these H-type fractures. This means that you connect the lumbar spine with the ilium and prevent further intrusion of this segment into the small pelvis. An example here, it's a 72-year-old female, immobilizing pain. The sagittal reconstruction shows distinct displacement between S1 and S2. So to prevent a further intrusion, we did a percutaneous iliolumbar fixation, or lumbopelvic fixation here with pedicle screws in L4 and 2 pedicle screws in the ilium and 2 connectors that are now not horizontally but vertically placed. It can be a horizontal connector between the vertical rods. Another example is a 63-year-old female. You see a void, not an alar void, a bone defect in the center of the sacrum. You see a fracture through that, and also a lateral fracture of the massa lateralis on the right side. On the sagittal reconstruction, you can see the bone defect and also the fracture. And here we performed, because we did not think that the bone defect would heal by itself. So a stronger reconstruction, stabilization with pedicle screws in L4, L5, and in the ilium, together with 2 very long screws in the S1 corridor. Shortly now about the anterior pelvis. If you treat the posterior pelvis operatively, you should also think to fix the anterior pelvis as well to reach a 360-degree stabilization. I showed you one patient with an early loosening of screws because the anterior pelvis was not stabilized. Here you have alternatives between external fixation and internal fixation. For us, the external fixation is not treatment of choice because of the low holding power, the lack of comfort, and the high incidence of pin tract infections in case the fixator remains for several weeks. So we prefer internal fixations, and you see several alternatives here. This is a patient that is treated with an internal fixator frame. So it's similar to the external fixator, just the connection between the left and the right pedicle screw is below the skin. And you see here the two pedicle screws. You see the rod that is not inserted yet. And on the right side, the rod is inserted, but you should place the rod in the subcutaneous layer and not in the muscle abdominal wall layer. But then you risk to compress the vessels and the nerves. And this is a publication in a case series of 6 patients. There were 8 nerve pulses from the femoral nerve. Some of them did not recover. You see, what we preferred is the retrograde transpubic screw, especially for fractures above the foramen obturatorium. This is most of the cases where you can perform this very well. In most of the cases, the corridor is available. You can calculate that with the CT reconstructions, and you should always use very long screws. You see that the tip of the screws is perforating the lateral cortex of the ilium, so that there is no loosening of these screws during mobilization. We looked back at 146 of these procedures, and this was high energy and low energy together. But we looked at the low energy trauma and found out that this is as safe as in the high energy trauma. There is a similar incidence of bone healing. We had an operative revision in about 13% of the cases. Finally, what is the outcome of these patients? And there are some publications. I have shown you the outcome in our group, with a difference in mortality and no difference in the intra-hospital complications compared to the conservative and the operative group. Here you see a study of Regensburg again, about 200 patients. What is striking, and this is very similar to what we have seen in our studies, there is a higher complication rate after operative treatment, if you calculate the in-hospital complications with the surgical complications together. But after 2 years, there is a significantly lower mortality rate in the operated group. Publication from this hospital here, 230 patients. Again, higher complication rate in the operative group, perioperative complication rate, but after 2 years, a lower mortality rate in the operative group. So to conclude, and that's the reason for the title of my talk, since about 10 years, there is an increasing interest in this pathology. If you look in the PubMed and you ask for pelvis osteoporosis, pelvis insufficiency, and pelvis fragility, then you see an explosion of the number of publications in this last 10 years. The same is true for sacrum osteoporosis, sacrum insufficiency, sacrum fragility. So I think perhaps this is related with the new classifications. In every case, we are confronted in our daily work with more and more of these patients. What did we learn in the last 10 years? Fragility fractures of the pelvis are a specific entity within the broad spectrum of pelvic trauma. The classification that we developed differentiates between different degrees of instability. All these patients present with comorbidities. This is a frail patient population. And we mean that the key factors for surgical treatment are the degree of instability. The more unstable, the more reason you have to operate. The delayed presentation, if the patient already had a kind of conservative treatment outside of your hospital and he comes in late, then I think you should operate early. And then the unsuccessful conservative treatment that you started. General in-hospital complications are related with the comorbidities and also with the length of hospital stay, but not directly with the type of treatment. But operative procedures produce a longer hospital stay, so you're not able to discharge these patients earlier than the conservative group. The percutaneous procedures that I described to you, presented to you, produce a low complication rate, I think. Iliosacral screws, very well known. Transsacral bar and retrograde screws are safe procedures in the hands of people that are experienced surgeons. There is a higher complication rate in plate osteosynthesis. Always, there is a reduction in quality of life and level of independency in all these patients, independent of the fracture classification and the type of treatment. So the classification does not give you a hint on what is better immediately after the operation in kind of functional outcome. The functional outcome is more related with the condition of the patient before the trauma. And I think this is similar with the hip fractures. The mortality is higher than in the reference population. You know, we started with a triple mortality, and now we are at a double mortality, about 10% of our population, thanks to less invasive surgical treatment. It can be reduced with operative treatment. Which questions are not yet solved today is what is the optimal timing of operative treatment, especially in the FFP2 group. You know, one quarter is operated, 3/4 is not operated. When should we decide to operate? What is the best type of operative treatment, especially in the posterior pelvic ring? I have shown you a number of alternatives. Is there a need for a preventive stabilization of the contralateral side if you treat a unilateral FFP? And is there a need for stabilization of the anterior pelvic ring if you have a stable osteosynthesis at the posterior pelvic ring? I think these are not yet solved problems, and there will be further prospective studies needed to answer these questions. Thank you very much for your attention. And if you want to have further reading about these topics, there is a book that I edited together with Alex Hoffman, and there are some large publications in GBGS reviews and Ffp1 instructional lectures. Thank you very much for your attention.